Right, I'm going to have to stand over here because I've got the near my laptop and the mouse, but hopefully you can hear me and see what I've got to say on the screen. I've got to talk for about maybe half an hour. It could be a bit of mission creep, it depends. Feel free to interrupt and ask questions if you wish. It's a very open session. So this is really what I'm going to do. I'm Paul Rajjayabun, I'm a consultant. I've been a consultant since 2008, so I'm not in the very early stages of my career, but I've still got a bit of time to go. I've been told I'll be retiring at 67. I'm currently 52. So a bit of time to go yet with my career and what I'll be doing surgically, which is why I was very keen to get involved with the robot, because we all know that robotic surgery is here to stay. It's the way that the vast majority of operations are going to be done here in Worcestershire, around the UK and around the world. So open surgery will continue, but the vast majority of operations will be robotic, which is why I became involved, because I've still got plenty of time in the tank left to continue operating. I've done some doctor management jobs. I was the clinical lead for urology for a few years, and then quite a senior job, the divisional medical director for surgery for all of Worcestershire for nearly 2 years, and that was really eye-opening, being involved in preparing for CQC inspections. And we all know that the Trust had some difficulties with the CQC. They're thankfully behind us, and it's because of that that we've been able to evolve new surgical techniques and get them robotic. So I'll cover some facts and figures about prostate cancer, just very briefly, for those that aren't familiar with some of the terminology. A little bit about the history of robotics in surgery, how I trained, along with Adele McCarter. I think Adele is here.
Nope.
But how I trained in robotics, because trying to learn something new is not easy. There are challenges, it's difficult, but we were supervised and trained to a very high standard by all the people involved. A little bit about our first cases, and something about the future directions. I have got some videos to show, so we'll see if they run. If they don't run, okay, we'll have to just say that we can't run them, but we're connected to the Wi-Fi, we're connected to the Trust, so if we can't get them to run, we've tried our best. So here we go. The prostate gland. There's a few ladies in the audience, but this is the male apparatus split down the side, like in the butcher's shop, and we can see what lives inside a man's pelvis. We've got the bladder, which stores urine. We've got the pipe that carries the urine out to the outside world, called the urethra. We've got the back passage, through which we check the prostate gland, and most men will know having a prostate check isn't particularly pleasant, but at least we can get to it. But when we put the finger in, we can only feel part of the prostate, we can't feel all of it. So it gives us a rough idea how big is the prostate. Is it smooth? Is it a Malteser or a Ferrero Rocher? Is it hard, craggy, or is it innocent? But of course there are bits that the finger will never get to. So here and here, we'll never feel that. So the finger test is just really a rough guide. And so we rely on things like MRI scans and the PSA blood test, of course, to help guide us to investigate men for potential prostate cancer. So that's the male apparatus, and we all know that as men get older, their prostate glands get bigger. That doesn't always cause problems. There are men walking about with enormous prostate glands. It doesn't cause a single issue for them. And there are men with relatively small prostates that have terrible trouble. But men are destined to get bigger prostates as they get older, just as their hair goes grey or falls out. And most men are destined to develop microscopic prostate cancer as they get older. If I had 100 men from the streets of Worcestershire aged 80 and above and took out their prostates, I'd find that 3/4 of them at least would have microscopic prostate cancer. The vast majority of those men wouldn't be destined to die. The vast majority of those men wouldn't necessarily need treatment, but some men do need treatment and intervention, and some men are diagnosed clearly earlier than the age of 80. Some of our youngest patients are now in their 40s, and I think this is a testament partly to groups like yourselves, word of mouth, good GPs and publicity campaigns by people like Ben Stiller, the Hollywood actor who was diagnosed with prostate cancer in his late 40s, and he himself had a robotic prostatectomy in the US. So people are talking about prostate cancer in a way that they never used to, I don't think. And we are diagnosing more and more men of all ages, including some men at very young ages now. Okay. Again, just for those in the audience that might want to know, we see different stages of prostate cancer. When we talk about robotic surgery, we're talking about generally localized disease, not disease that's expanded and got outside the prostate to breach the capsule or go to lymph nodes or other structures. We're talking about localized prostate cancer. But here you'll see in the diagram, T1 is really prostate cancer that you need a needle to detect. You can't feel it, you can't see it on a scan, but it's picked up on a biopsy. T2 is where we put the finger in and we might feel a small nodule. Or the MRI scan might detect an area that doesn't look healthy. T3 means that the prostate cancer is escaping the prostate, breaching the capsule of the prostate, just like the plum skin analogy that I use with patients, or penetrating the sperm sacs at the back. Because around the back of the prostate are two sperm sacs called the seminal vesicles. And the prostate cancer cells, sometimes if they're aggressive, invade those structures, and that leads to what we call locally advanced disease. And then unfortunately some men are diagnosed with prostate cancer which has escaped the prostate and invaded nearby structures. So unfortunately today in my clinic I saw a man in his early 60s, his prostate cancer clearly on the MRI scan had breached the prostate, was invading the bladder neck and was into his seminal vesicles, and also unfortunately had no disease positive on his MRI scan. He was in his 60s. The question is, if he'd had a PSA at 55 or 50, would we have been able to catch him before it was too late? And unfortunately for him, we're not going to be able to cure him. We can treat him, of course, and we can manage his disease, but it would be very difficult to completely reverse that situation. So prostate cancer is rare in men under 50, but we are seeing more and more men in their 40s. And the gentleman that I was speaking to today has 2 brothers and 2 sons. And I've told him that he needs to get his family to go and have PSA blood tests. 2/3 of prostate cancers are detected in men over the age of 70, so the audience here, I'm not going to do a straw poll, but that could be the territory that we're talking about, with actually the peak incidence in men aged 75 to 79. You see the figures here. Prostate Cancer UK quote this all the time. 1 in 8 men will be destined to be diagnosed with prostate cancer in their lifetime. And if you're black or Afro-Caribbean, that is 1 in 4. Not necessarily a problem that we see so much here in Worcestershire, but it's a fact which nobody can escape from. Roughly, in the UK, and I think this is sort of pre-pandemic, and we'll come to the pandemic in a minute, around 52,000 men are diagnosed with prostate cancer every year in the United Kingdom. So I don't know, who follows football? Who's got a stadium with about 52,000?
Newcastle. That'll be down London way.
Newcastle, yeah, I'm a Sunderland fan, unfortunately. So yeah, Newcastle about probably 50,000. Villa's about what, 42 on a good day. So if you put it in that context, a whole football stadium of men are diagnosed with prostate cancer in this country every year. The projected number of diagnoses per year by 2038 is 85,000. So we're going to be hit by a huge wave of men with prostate cancer, and we're not, I don't think, prepared to deal with that in terms of the resources that we have within the NHS. But that's a huge rise in numbers because I think there'll be more testing and there'll be men living longer and longer. And we see it here in Worcestershire all the time, men living to their late 80s and early 90s, leading very active lives, still playing golf, still going out and about, still driving. And that I call the Worcestershire effect. Of course it happens in other parts of the country, but I think it's very keenly felt here that lots of men remain very active and want to remain active. And you say to a man, how long do you want to live for? They say forever around here. They really do. And there is something in the water. I think people live a long time here. They've got relatively healthy lifestyles. There isn't an awful lot of deprivation compared to other parts of the UK. And also GPs are pretty good. So if you go and see your GP nowadays and ask to be checked or tested, they'll normally help you. If you go to your GP with symptoms, they may say, let's do a prostate check, let's do a PSA. Other parts of the world, or in this country, that doesn't happen. I've worked in other parts of the Midlands, and lots of people don't know anything about PSA testing and know very little about prostate cancer. That isn't the case here. And people read the papers, they go online, but it's everywhere. So the more people talk about it, the more people will be diagnosed, looking forward for investigations. So you can see here, this is the age at diagnosis, and you can see the peak in men as they get over the age of 70. And these are the projections for the coming years, and the line is only going one way. I think that projection will need to be modified when we start to factor in the pandemic and the disastrous effects it's had on diagnosis of all sorts of conditions, not just prostate cancer. So, although a lot of men are diagnosed with prostate cancer, as I said, not all men are destined to die from it. Of course, people are intercepted and treated, but still, each year we have about 12,000 men lost to prostate cancer. That accounts for 14% of all male cancer deaths. And it is a little bit unusual that we don't have a screening program for a disease that causes so much devastation. It accounts for 7% of all cancer deaths, male and female. So this is a big hitting problem for the population of the UK. The mortality rate has been dropping as people have been diagnosed and treated, etc., etc. And we have newer and more novel treatments for even men with advanced cancer, which we never had before. Even a year ago, there are agents that we're now using that we weren't using 12 months beforehand. But I think that curve is going to have a wobble with the pandemic impact, because we're going to be picking up people later in their clinical journey, and we're going to be finding people with perhaps more advanced prostate cancer, not the T1 microscope, not the little nodule, but those men with a prostate cancer that's penetrating the capsule or breaking into the bladder, like the poor gentleman that I saw today. This is a real-time problem, and it's going to, I think, unfortunately, going to get worse before it gets better. So I was very pleased to hear about the missing men. So when Peter Corbusier called me and kindly had a chat with me for an interview, I raised this point about prostate cancer diagnosis and how things are not happening in the way that they used to when it comes to the number of people that are being tested. So as a consequence of the pandemic, the rough figure is around 14,000 men were not diagnosed during the pandemic. Where those 14,000 men are, we don't know. Are they coming all forwards now in an en masse, or are they remaining undetected? And I think time will tell. So Prostate Cancer UK had their Missing Men campaign, and I think it's really commendable that locally we're trying to capture those men that were missed because they couldn't see their GP, or because they put things off, or because basically they just couldn't access any investigations or services. Because I'm constantly told that it's not a dig at GPs at all, but it's very hard to see your GP. And of course you can't check a prostate over the phone. The other thing was that Prostate Cancer UK have picked up that there is a specific cohort of men, older men, and by that I mean men in their late 70s and early 80s, men from poor socio-economic backgrounds, and men from ethnic minorities. They've corralled this group of men and called them the seldom heard, hard to reach. And so there's additional pressure coming from the campaign to try to identify these men. And also pressure that older men should have access to treatment. We're a bit of an anomaly here in Worcestershire. We've been called out by many of the departments and units around the Midlands for being a bit aggressive in how we manage our prostate cancer, and that means operating on people over the age of 75, irradiating people with curative intent over the age of 80. If you live in other parts of the West Midlands, you will be not offered a radical prostatectomy if you're over the age of 75. It just doesn't happen. If you are over the age of 80 and live in other parts of the West Midlands, you will not be offered radiotherapy to cure you. You'll be given hormone treatment, which, as we know, is palliation. It's not cure. But the reason that we're different is because we know that men will live for 80 to 90 to 95, and therefore we're trying to ensure that prostate cancer doesn't interfere with their later years. So we have been told that we're an outlier. We've been written to say that we're an outlier, but guess what? the rest of the country is now trying to catch up because they realise that men should not be denied access to treatment just because they're a bit old. So that was the other group that Prostate Cancer UK were trying to target. This isn't sensitive data, but it's data from your local trust. I don't know what they think about me sharing it with you, but I don't think I'll be in any difficulties or trouble. What we can see here are the red line is the number of cancer referrals that we would receive in a month, dating back to January 19. So the pandemic was February, March 2020 is when it all started. I caught it very early, actually. I was one of the, I think, early adopters of COVID. I've had it about 3 times, and that's because we're constantly involved with patients. We're constantly exposed to people coming in and out of our offices. And as we know, unfortunately, some doctors died as a consequence of trying to deliver services during the pandemic. So it was a dangerous time. I think we look back now and go, oh, was it all necessary, etc. And that will be investigated and dissected, I'm sure. But at the time, I think we were in a very difficult situation. Patients were dying in front of us of COVID. So we can see here the number of referrals that we receive for a cancer question mark in urology alone. And the blue is the number of patients that are then diagnosed with cancer in their urological system at the same time. So we call that the conversion rate. So you can see number of referrals, number of people diagnosed. And guess what happened when the pandemic came? It drops off an absolute cliff. So patients were not being referred, patients were not being seen. And every wave that we had during the pandemic, whether it be Omicron or other variants, we saw drop-offs as lockdowns kicked in and as everybody else turned their attention towards fighting the pandemic. So all of these patients here dropped off, and it's this group here that are missing. They're the patients that are missing from the diagnosis of urological cancer, and the vast majority of urological cancer we diagnose is prostate cancer. There has been a recovery. We've seen more patients come forwards now, and this is causing us a problem because lots of people are coming out at once, and we are being overwhelmed because we just haven't got enough resources, enough MRI scans, enough expert nurses to counsel patients, enough people to do biopsies, enough people to look down microscopes, because so much work is now coming forwards all at once. This figure is very telling. Pre-pandemic, we diagnosed around 700 men each year with prostate cancer. One of the highest rates of prostate cancer diagnosis in the Midlands, if not the UK. We have one of the highest rates of prostate cancer per capita population compared to anywhere else in the West Midlands. And your local urology service is having to deal with that with probably half the manpower that we should have to deal with it in a comprehensive way. So we diagnose nearly as many prostate cancers as the whole of the North Midlands, just in this patch with a population of 600,000. They have 1 million. So in 2020, the figure fell to 474, and in 2021, it fell to 424. So this is the missing men of Worcestershire that were not diagnosed because they couldn't move forwards, they couldn't access services. Things are recovering. We diagnosed in 2022 about 510 prostate cancers. So still below the 724 that we saw before. So the number's gone up, but still nowhere near where we were. And we've received probably the highest number of referrals for urological cancer that I've ever seen in 2022, 3,500. So people are now coming out, but they're coming out in a large wave. So, did I miss a slide? I don't think I did. They're coming to localised prostate cancer, so that's why we're talking about a robot. We're talking about dealing with people with prostate cancer that's confined to the gland. What are the options? Active surveillance, and we've got lots of patients on active surveillance. We diagnose low volume cancers, which are low grade, and we don't do anything. We keep the patient under review, regular PSAs, regular MRI scans, sometimes a repeat biopsy, sometimes a template biopsy, which is extensive sampling of the prostate, but we don't treat them because we're concerned that if we treat them, we're going to over-treat a disease that was never going to be dangerous in the first place. I've got a patient on active surveillance It's been with me for as long as I've been a consultant. So since 2008, we haven't done anything. He hasn't needed treatment. Nothing has changed. And so for some men, it's the correct option. Radical surgery, of course, and radiotherapy. With surgery, that can be either an open incision, and sorry about the picture, there's a few pictures that might make you put you off your tea. That's a radical prostatectomy incision. So it goes from the belly button down to the pubic bone. It's quite big. And it takes about 5 days in hospital before you're ready to go home. And I reckon it takes about 3 to 6 months, if not longer, to get over an operation of that magnitude, that incision. But for certain men, it's still the right thing to do, an open operation. But then, behind open surgery came minimal access surgery, keyhole surgery, if you like. And the term for keyhole surgery is laparoscopic surgery, but specifically, laparoscopic surgery involving a robot is called a robotic prostatectomy. And whenever you're looking at any of these treatments, you're looking at the outcomes. How good is it at curing the man? Will the man be left incontinent or dry? Will it affect sexual function? How long will it take for the man to recover from his operation and get back to normal? Will he need a blood transfusion? How long does he spend in hospital? All of these things we look at when we look at the treatment options for prostate cancer, and also they're important considerations clearly for patients. So some men are carers for loved ones. They don't want to come in and have an operation that's going to keep them out of action for 3 months. So they elect to have radiotherapy. So minimal access surgery, smaller scars, less pain, faster discharge, back to work quicker. The government likes that. Doesn't it? HMRC. Okay. This talk, actually, I gave a talk, you might remember, Mary, Kidderminster, around 2010.
Something like that.
We were talking about robotics then, weren't we? And I spoke to the group. It was a smaller audience, but I spoke to the group at the Kidderminster Hospital. And these slides are from that talk. So these are the sorts of things that used to happen to patients. I'm a kidney surgeon by trade, but now I do prostate cancer surgery. These are the sorts of incisions that you need to take somebody's kidney out. So that's here. This is a horrible incision. It's very painful. You can't breathe afterwards. You're sitting down for a chest infection. But that was the scar that you needed to have your kidney removed. This is another scar which is used for general intra-abdominal surgery. This guy recovered from this operation is amazing. But he did. Look at that incision. That's going to need a lot of morphine. Can you imagine trying to stand, trying to do your shoelaces, trying to do anything after that incision? But with minimal access surgery, and you might not be able to see at the back, we make small incisions the size of my thumbnail, and we put telescopes inside, gadgets and instruments, and we do the operation whilst in conventional laparoscopic surgery, holding the instruments, and I'm looking at a telly, and I'm trying to get the kidney out. Of course, one of the incisions needs to be made bigger to pull the kidney out in a bag, but that incision's about that big, and it's normally down here, and recovering from an incision down here is a bit like recovering from an appendix operation, whereas recovering from that is not like getting over an appendix operation, it's like being hit by a truck. So that's why we have minimal access surgery, because the scars are smaller, it's less traumatic for the patient, they recover quicker. So where does robotics fit with minimal access surgery? The concept of machines that can do stuff on their own is not new. I didn't do classics at Bradford Grammar School, but I did do Latin. Aristotle, 400 BC, came up with the idea of a machine that would serve the gods, and also came up with the idea of a machine, a sequence of wheels and cogs that would work independent of human interaction. 400 years BC. Da Vinci, a la the robot, Da Vinci was talking about, amongst many other things, autonomous machines. I think if you look online, you'll see a suit of armour that he created that apparently could do stuff on its own, move its arms, open its visor, and all of these things. The word robot is a Czech word derived in 1921 from a Czech playwright, and it talks about forced work. That's what the word means. And industrial robots, we all remember British Leyland. I'm old enough. Every time I drive through Northfield, it's all gone now. It's a big Marks and Spencer's, isn't it? But we remember those amazing videos of robots welding bits of car together, and that's all still happening now. I've got a friend who works for JLR, and he spends his whole life programming these things. So robots are not new, they've been around for a long time, before Christ. But why did robotics enter the medical world? Well, as ever, unfortunately, a lot of developments come off the back of war and conflict, and that's where the money is. So America, I look at the figures now, and I don't actually think they're that big, but anyway, America years ago was very interested in developing telepresence combat surgery. So your soldier was blown up, shot or otherwise, was retrieved from the battlefield, taken behind lines, and then operated on, but with the surgeon nowhere near the war zone. This was the idea of how medical care would be delivered in the military field. And so they spent $212 million in trying to develop the concept of telepresence surgery. They spent $12 million on one idea called the trauma pod concept, but it never really worked. I think it was just too difficult to pull off. But medical companies jumped on this idea, and so began the idea of robotics in human surgery. Now let's see. Forgive me if it doesn't work. Okay. So this is the trauma pod. This is where they spent their 12 million. You can see the patient being monitored. It's not a real patient, of course, it's a mannequin. And there are no humans in this theatre. This is a robot that's next to the patient. There's no nurse next to the patient. There's a machine doing this and that. Here's the surgeon controlling the instruments. There's a bit of bleeding. What are we going to do? We need a swab nurse, please. So here's the nurse giving the swab to the robot. The robot will then pick up the swab and dab the blood. Crikey, I don't know what battlefield injuries they were hoping to deal with this. Probably only a thumb cut. But, anyway, this was the inception of robotic surgery. So these instruments actually look very similar to what we're using now in the trust. But this is where it came from. General Dynamics are the company that developed that robot. Okay, so that's a very old film. It's embedded in my laptop, which is why I had to bring it. You can't find it now. Okay, it's obsolete. This is an obsolete video. Here's an instrument change. Okay, we need to change from the scissors to a grabber, and this is what that poor patient. He's not even anaesthetised, though. So this is an instrument change. We're going to change from one instrument to the other. And this is all done without a human being anywhere near the patient. This was the dream. But this is the reality. Okay? This is the sort of team that you need to deliver robotic surgery. You can't do it without humans. And you never will be able to do it without humans. Or certainly not in my lifetime. You're always going to need a human or two. So you've got scrub nurses, surgeons, helpers, bedside assistants. These two guys have been critical in us getting our robotic program going. Without them, it wouldn't have started. Mo and Wayne. People to help move the patient, people to put the patient to sleep, people to help the anaesthetist. And I'll tell you, if it starts to bleed quickly, you don't want to wait 10 minutes for a swab. You need a swab there and then. Okay, so you have highly trained people to deliver robotic surgery. But now it's normal to have robotic surgery. In many aspects of urology, of course, the vanguard operation was prostatectomy. We want to use it for kidney surgery, to take kidneys out completely or to take bits of kidneys away. It's called partial nephrectomy. We want to use robotics here in Worcestershire to do cystectomy, which is removal of the bladder for bladder cancer. But other teams, guess what? They're interested in using the robot too. Bowel surgeons, gynecologists, ENT surgeons, lots of other teams now have woken up, smelt the coffee, and they know that they need to start robotic surgery because other units all around them are doing exactly what happened to us. In the past, we used to do around 220 radical prostatectomies a year. Because of other robots in other centres, that figure went down to under 100. So that meant patients had to travel to Wolverhampton and to Cheltenham. We had no control over what happened to those patients. And it meant, of course, for those that were interested in finance, that the income associated with these operations was siphoned away from the county. It went to Wolverhampton, Coventry, Cheltenham. And without that income, then that puts your services on a bit of a shaky ground. The Da Vinci system is the system that we have here. It's a system that we asked for. It's the XI, which is, I would say, the most sophisticated robot out there. There is another robot, it's a British robot, called the Cambridge Medical Robot, Versius. It's a nice system, it's different, it's smaller, it's modular, it's more mobile, it's cheaper, but it's just not as good. Okay, I've been on it, I've tried it, I've been to Cambridge twice. It might be fine for other if you want to take somebody's gallbladder out, fine, use one of those robots. But if you're trying to do complex and sophisticated surgery, like taking out a piece of somebody's kidney or taking out a prostate gland, then you need the best. Okay, it costs about $2.5 million if you want to buy one of these things. Very few hospitals buy them. They rent them, they lease them. They don't buy them. They don't ka-ching 2.5 million. Although some of the early robotic centres in the Midlands did buy them up front. They somehow got money, donations, who knows how they did it. We raised an amazing amount, $500,000. $500,000. Okay, that'll buy you a few arms. So we had to cut a deal with Intuitive that it would be rented over a 7-year contract. The robot needs to be maintained, so there's a bill for that, $150,000. The instruments, they don't go straight in the bin, but they're used for about 10, 12 times, and then they have to go in the bin. So those are costs that you can't recover. So it's a very major investment, and that's why the trust, I think, had a big wobble over the robot, because they were worried about the pounds, shillings, and pence and what it would do to the financial situation of the trust, amongst other things. But it's a major investment, and we got it over the line eventually after an awful lot of difficult times, and thanks to you guys and the support group and Ian and all the people involved in raising every penny. It did come over the line eventually. Around 7,500 robots are found in the world. They're mainly all Da Vinci systems, but other countries are buying the Cambridge system. Intuitive, the company that make the robot, their revenue is 5.7 billion per year. So if you go back to that slide about 12 million for trauma pod and $200 million for the US Defense Agency, this is a tiny amount of money compared to the money that flows through Intuitive. Okay. But they're up against it now because there are competitors, and they're starting to drop their prices. And if you start to drop your prices, you start to lose revenue. But they still make a clear profit, about 1.5 billion. How tough? How tough are those guys?
What happens if they drop the prices and the quality drops?
Good question. I think the quality shouldn't change. The standards are very high in the manufacturing. I think what will happen is the share price will start to fall, and then they'll feel a bit of a squeeze. But they've got the market cornered for now. and will probably continue to have the market cornered for the foreseeable future. But there are other robots. There's a Hugo robot made by another company called Medtronic, and other robots are just in the background. But they have to go through a lot of testing, approval, kite marks for human use, and it takes ages. Cambridge were talking to us about 6 years ago, saying we're going to get our kite mark, but it never came. Year after year, it never came, and then they eventually got their approval for use in humans. So just the basic principles. Laser pointer, that's what I needed.
Sorry.
Humans. Need the humans. Okay, here's the robot itself. This is our theatre. This is the robot in the Alex. It's quite a tight space. They had to spend a bit of money strengthening the floor, raising the ceiling, and doing some other work, taking down some walls so we could fit this thing in. So you've got, if you like, the patient side bit. You've got the brain of the robot, which then generates the images and controls energy and other elements of how the robot works. And then in the corner you've got the console, which is where we sit and control the thing. So unlike laparoscopic surgery where I stand and hold the instruments right next to the patient, we sit in the corner of the room and we control the instruments whilst looking down a 3D viewfinder. But you need somebody by the bedside to change the instruments or get the swab, and you need somebody by the bedside to put clips on or suck blood or just generally assist. So the bedside assistant is really important. The advantage of robotic surgery, it's a 3D view, so when I'm doing conventional keyhole surgery, I'm looking at a monitor, telly like that, flat. When I'm looking in the console, everything's in 3D and it's in HD. We can magnify the image either by making the camera go closer, or you can do a digital zoom if you wish, so you can zoom in on structures. For those surgeons that have problems with a tremor, they do exist. I've got pretty steady hands, thankfully, still. But if you have a tremor, it's all cancelled out by the robot. So there is no tremor in the instruments. Nothing. The instruments are rock steady. And the real difference with robotics compared to laparoscopic is that when I hold an instrument in my hands and do conventional keyhole surgery, I can go in, I can go out, I can go up, I can go down, I can go left, I can go right, and I can rotate, and that's it. But with a robot, you can do all of that, but the end of the instrument can articulate, just like your wrist. And this is really important when you're trying to do tricky things in the depths of the male pelvis. So they call that endo-wrist technology. Of course, it's not the be-all and end-all, and the robot isn't a panacea, and it's never going to replace open surgery for some situations. It's expensive. You don't feel anything. So if I'm holding the instruments inside the patient using conventional keyhole surgery, if I nudge something, I know exactly how hard I'm pushing, and if it nudges back, I know exactly how hard it's nudging back at me. With the robot, you don't get that. You're disconnected from these things. But it's amazing how the brain and the hands and the eyes compensate for that. So although I can't feel what I'm doing, I know roughly how hard I'm pushing, and I'm seeing the tissues yield in a way that I can't normally do with conventional laparoscopic surgery. And of course, setting this thing up takes ages. We were talking about getting a robot in 2007 when I was the registrar in the department, 2007. So setting up the whole program, other trusts didn't wait and they got on with it. But even just setting up the program, training staff, upgrading theatres, buying the thing, renting the thing, and then even just moving the robot and docking it with the patient, it all takes time. So how do you train? What did we do? So you have to go online and do hours and hours of watching videos produced by the company that make the robot. You then have to do simulation training. So you'd be pleased to hear we didn't just start having a go. We spent 40, 50, 60 hours on the console, which has got on the back of it simulating a box, and that has loads of programs and things that allow you to start to understand how to move the instruments, how to move the camera. We went and visited other units, so we went down to Guildford and saw the guys down there. They were brilliant. Went to Bristol and had a look around there at their robotic service and met the surgeons and team there. They were very helpful. We also went down to London. So the four of us, Adele, McCarr, myself, and the two guys, Mo and Wayne, we went down to London and we were assessed. Had we done our training? Had we been doing our homework? And were we safe? And we were signed off after a day's assessment in London. And then when we started with the first case in October, we didn't just, again, hope for the best. We had surgeons come from other units to be with us, and they were with us for a number of months for every case that we did. The first case, of course, was a momentous moment. I'll never forget it, holding the scalpel. But the first case, we did hardly anything. We doctored a thing, did a bit of this, bit of that. But the mentor did the vast majority of the operation. But then as we gathered more and more experience, the mentors did less and less. So it became 50-50, and then 25-75, and then eventually we did the whole cases independently. Still with a mentor, and then the mentors officially signed us off to say that we were up to scratch. But still, we've done 30 cases. When we've done 300, when we've done 1,000, when we've done 2,000, we'll be in a different position. And in fact, the progress that we've made in the period from October is actually, I think, quite remarkable, because we've had to contend with strikes, flu, winter pressures, you name it. Trying to start this service in the middle of winter has been pretty tricky. And a few weeks ago we were in Vienna having some advanced training. So that's just like the online stuff that you see. If you go to the website, this is all the videos that we have to click on and watch, sign to say that we watched them. Now here we go. Let's see if this works. Okay, let's see. Bear with us. Let's see. Okay, this could work. Let's try again. Go back to hands. Okay. Yeah, so we spoke about simulation. You can watch this video on YouTube if you want to. You don't have to be a doctor to watch it. But this is like when you start to do the simulator to understand what it's like to look down the periscope and to start to handle the instruments, you go on a simulator. And the complexity of the simulation goes up as you get more experienced. So if you look at the top right, you can see the guy moving his hands, because it's all done with your hands mainly, and he's moving his hands to control these instruments. And the objective of this exercise is to pick up the matching coloured ring and drop it on the spike. Okay? And they call that C-spikes. It's very entertaining. It's a good starting point for robotics. And it gets your eye in. And in fact, some surgeons would advocate going on the simulator before you start operating on a human. So a bit like an athlete might warm up, have a go on the simulator beforehand. So that's the first exercise, C-spikes.
I'm sure I did that on the Blackpool seafront when I was in
You may
there.
well have. This one's a bit more complicated. This one is to not only get you to understand how to move the arms, but how to coordinate camera movement and also switching from one arm to another. So you've got two hands, but there are three arms that you can control and one for the camera. So your foot starts to take some action now in changing and controlling, they call it clutching and arm exchange. So the objective here is to use your arms to open the doors and then pick up the matching coloured shape and then drop the shape into the slot. And they call this one three-arm relay. It's quite mind-boggling when you start doing it, but when you get the hang of it, you understand that you're learning how to do robotics. And when we went to London, we had to do these exercises and be watched, and we had to achieve high scores before they would then let us carry on with the rest of the day. Quite nerve-wracking. And then lastly, because we have to do stuff inside patients that involves needles and stitching. This is another simulator which simulates picking up needles and driving it through tissues and then picking up needles again. So here you can see again the surgeon's hands controlling everything. You can see the wrist articulation that I described, and you can see here's a needle. This is the patient's tissue, and the exercise makes you drive the needle through the tissue very accurately. And again, when you first start doing this, you think this is a rubbish it doesn't know what it's doing. But as you learn more and more, you can become very, very accurate with needle placement and picking up needles and not dropping them. So we had to do hours of this before we went anywhere near a patient, and I'm sure you're thankful for that. Here's the unit in Guildford. The only reason I'm showing this is, well, there's Mr. McCarr telling them how to set it up, of course. And you've got it all wrong. But this is a slightly bigger robot theatre, and space is a premium. But can you see here the difference? There are two consoles, and that means you can have two surgeons sat looking at the same operative field, and they can change who's in charge. A bit like a driving lesson, but with dual control. So that is very helpful for training. The Trust elected not to go for dual console because it was an extra 200 grand. And so when we're talking about future directions, where do we need money, it's for stuff like this, stuff to enhance our service, stuff to make our unit a desirable place to come and learn robotics. If you've got a dual console system, then that makes it more attractive, makes it easier to train. But it comes at a cost. We'll have to knock some more walls through to get one of those into our little theatre. Mr. Patil, I will mention him. He is the guy in Guildford who's been up and down to Worcestershire so many times. He's stayed in every hotel in Redditch. He's there every morning, 8:30, to do the team brief with us and help us and guide us. And he's been there from the beginning, and he's the guy that signed us off. So a very, very generous surgeon. He's in his 70s now. He's in his 70s. He won't stop. And he enjoys teaching and training. And people like that are so important. He got paid, of course. He was paid. He wasn't just loved it. This is our trip to Vienna a few weeks ago. We met some European urologists. They were a bit icy, let's say. It's nothing to do with Brexit, of course. But anyway, nonetheless. They were this guy here, Prof. Nedden, very experienced robotic surgeon. He does kidneys, prostates, bladders, and can do a prostatectomy, he says, in about 45 minutes. Our first one took 6 hours.
How long have you been doing it?
Oh, years. And our op times are coming down to 3.5 hours now, and we expect them to drop more and more as we do more and more. But these are the sorts of things that the team have to go and do. They were giving us tips and tricks, and we were operating on animal material, not live animals, animal material to help us understand some of the nuances now. Now that we've got the basics out of the way, some of the nuances about tips and tricks. It is official, so I was signed off. This isn't fake, so I am certified, approved, passed all the tests. And that's what you want, I suppose, in your surgeon. Now then, here we go. Another challenge. Okay, so this is inside a Worcestershire patient. I have spoken to him today. These are very short videos. He knows that I'm showing bits and pieces of him. Okay, he has no problem with that. He signed consent forms and everything about images. There's no way you can know who this is. There's no name. But nonetheless, I just thought it was courteous to say that I was showing bits to strangers, albeit enthusiasts. Okay, I might have to play this video a few times, but just to show you, grasper. Remember I was talking about the sperm storage sacs at the back, the seminal vesicles? That's one of these. So we have to dissect the seminal vesicles out from the surrounding structures, and the robot allows us to do that very accurately with precision.
What's the magnification on that image then? I mean, what actual size?
That's the camera's right close. The camera's close. So you can see we're using scissors, we're lifting the seminal vesicle, we've got energy coming out of the scissors that allows us to cauterize blood vessels.
So that's actual size?
That's actual size. Here's, just to show you again, we're lifting the seminal vesicle up from underneath there is the rectum, above is the bladder. We need to get the seminal vesicle out, along with the prostate. Let's see this bit here. Okay, this one here. All this is to show is the dexterity of the instrument. So here's the prostate, here's the catheter. We're about to lift the prostate up and you can see what we can do. We can rotate the instrument round and completely change the configuration of the operative field. And you can't really do that using conventional laparoscopy. Let me show you that one again. 1 minute, the catheter's pointing to the floor. Next minute, with a flick of the wrist, it's all the way up. And the thing about robotics and keyhole surgery, and surgery in general, is all about tension and pulling things in one way so that you can snip it in another. And so the robot gives you excellent maneuverability and dexterity. And then finally, this one might be hard to see, but this shows us trying to stitch the urethra. So here's the patient's catheter, so outside world is here, catheter through the urethra, that's why I did that little anatomy lesson at the beginning. Catheter here, and here's the urethra, there's no prostate now, it's gone. Here's the bladder, and what we want to do is put a stitch between the bladder and the urethra. Very difficult to do using conventional laparoscopy, but with a robot we can do it relatively easily. You can see a flick of the wrist, the needle is driven through the urethra and we grab it with the other instrument and pull it through. That takes literally seconds. To do that using conventional laparoscopy would take me about half an hour. Okay. Show you again. The needle is passed through the urethra with great accuracy. If we're not happy about the position, we can take it out and reposition it. And then we grab it. And that's to stitch the urethra back onto the bladder. All of this is in a very confined space under the pubic bone. So with the patients, they've all been given very careful counselling and consented for robotic surgery. I think the first patient was clearly a very brave patient, but he was given all the assurances that we had experts with us, and somebody always has to be the first. But yeah, his operation went smoothly. He was ready to go home essentially within 48 hours. Wow. Remember, the open operation is 5 days. We have our CNS nurses, here's some of them on the right, who are trying to set up a surgical school so that when patients are told you need to have operation, a robotic prostatectomy, they're given information, directed to videos, resources, etc., to help them to prepare for before, during and after their operation. They're calling that surgical school. That should be up and running very quickly soon. We've done 30 cases. Well, tomorrow will be 30. I'm doing tomorrow's case, so I'll be going to bed early and preparing myself. But we've done 30 cases, and we've seen, certainly over the last few cases, the operative times drop, and we've seen the time that it takes to dock the robot next to the patient drop, and we are seeing patients going home the next day. Some of these operations are lasting a long time. The patients wake up a bit disorientated because we have them head down and that puts a bit of pressure on the brain, but that all clears within a couple of hours and many are ready to go home the next day. Not all, many are. One patient said, I don't believe I'm ready to go home yet, I don't trust you, I want to stay another night. He was absolutely fine, he could have gone home, but he wanted to stay. We're doing roughly 1 or 2 cases a week. Really, if we were given the opportunity, we'd do a case every day. But that doesn't seem to be possible at the moment. But we would, because of theatres and staffing and you name it, because only certain staff members are trained in how to help with the robotic procedures, and they're small in number. So if we wanted to do, I mean, Mr. McCarr and I would operate every day, all day, but it's the team around us that we have to think about. You can't go anywhere without the team. Think of that picture I showed you of all those folk needed for one of these operations. So we're happy to work, and I'm not saying the others are not, it's just that they're pulled to other theatres to do things, and so we can't do surgery every day, but we would if we could. This is the open incision, remember, and these are the small incisions on the front of the tummy. We put the telescope in, smaller trocars, we call them, through cuts the size of, again, my thumbnail. One of the cuts needs to be made bigger though to pull the prostate out, but that's still quite small, depending on the size of the prostate. It's going to be about that big. So we're looking carefully at our outcomes. We're not marking our own homework. Other people are reviewing what we're doing, looking at length of stay, blood loss, cancer margins, all these things. Of course, I don't think any unit, if we were to ask them, can you let us know how you got on with your first 30 cases so we can compare? I don't think any unit would give us that data. Okay, that early phase of the learning curve is very tough. But we've had short length of stay, 24, 48 hours, no blood transfusions required, no major complications. You can do damage inside a patient with this instrument, with this technology, but thankfully no major complications, and I hope that continues. No conversions, so we haven't had to get the scalpel out and do the old-fashioned operation halfway through. And what we have seen is rising demand. So patients who are on the waiting list for an open operation are now ringing, saying, I've heard about the robot. Can I change my operation now from an open operation to a robotic operation? That's happening very regularly now. In some patients we're saying, that's not the right thing. In others we're saying, fair enough, we'll put you on the waiting list. The waiting list is, of course, like everything, a topic of great discussion and conversation at the moment. Last few slides. I don't know if any of you have seen this article.
Yeah.
It's Jeremy Langmead. I've not met him. I actually know of him, and I've met his husband, who runs a gastro pub in the Lake District. But this guy, Jeremy, who I've not met, but for those of you who go on Instagram and all that sort of stuff, he's quite a big cheese on there. He's a magazine editor, and so circulates in the media world in London, and was diagnosed with prostate cancer at 56. And so he writes eloquently and sometimes a bit brutally about his journey from investigation to diagnosis to robotic prostatectomy in London. And that article I would encourage all of you to have a look at or share it. It's on the Sunday Times website. If you Google Jeremy Langmead prostate cancer, you'll find it. The Sunday Times normally don't let you read their articles. You have to pay a subscription to read their stuff, but they dropped the fee for this article, and you can read it and share it. So if he's writing about it, age 56, in London, and it's in the Sunday Times, more and more people will be asking about testing, diagnosing and treating prostate cancer. So in the future, what do we want? We want another console, I've mentioned that. Is there a bucket, Mary? I think the Trust definitely needs another robot. It needs either a Cambridge robot or another Da Vinci system to meet the requirements of other specialties, because guess what? They're very interested in coming to see our robot for their patients, for all the benefits that I've described. We want to start doing kidney surgery quite soon. We want to start doing bladder cancer surgery quite soon. We want to become a training centre for robotics where other surgeons will come, and maybe one day I'll go to other units and supervise the departments that are starting up a service. And that would be brilliant. That would be professionally very rewarding. We still need fundraising. I think the charitable fundraising that was achieved, although it was very painful and difficult, was so instrumental in getting the robot over the line and into the building and the first patients treated, and we're eternally thankful for that. But I think we're going to need some more money. I'm not sure how that's going to come about. There is a trust charitable department, and they're quite light touch with us at the moment, but I think we'll be knocking on our door saying we need some more cash to get another console, to expand our services. But Rory the robot, he's not called Rory day to day, but I don't think we'll be dropping that name.
What do you call it then?
Don't keep that to me, my own private world. It is an amazing machine, the technology is phenomenal. So just to finish, robotic surgery is here to stay, it's not going anywhere. Interestingly, I think other hospitals not so far from here are getting robots. Hereford, Shrewsbury, to name a few. You could say, well, hang on, how do they need a robot? They don't do prostate cancer surgery. Well, they might want to, and they might want robots for their other services. They've seen the writings on the wall. If you want to offer surgery to your patients, you need robotic systems. I think the backlogs and the pandemic effects were going to linger, and I'm really worried about these men and other patients that haven't been diagnosed with other conditions that are going to come out of the woodwork over the coming years, and we're finding people are coming with later disease, more advanced disease, and disease that's spread because we didn't get them soon enough, or get to them soon enough. And that's going to linger for a while, maybe a generation. Patient-driven demand is real. I think this is a fantastic turnout for a talk like this. And you might go away and start talking to friends, family or otherwise, or you might not. But awareness is rising, the robot is rising as a concept, and people are asking for the operation, and they're going to get it. And I think what's important though is, despite everything I've said, we need to look at the results. Are we curing people in the same way? Are we making them incontinent or continent? Are we preserving sexual function? Are they having complications? I think it's a bit early to make judgments on that. I think we need to do at least 100 cases and then look back. So it's very important that we remain one of the leading providers for urological surgery in the West Midlands. It's important that we have robotics, and that's central to our survival. And new consultants now have been appointed to our team. We couldn't appoint anybody for years before the robot came. Now we have 2 new consultants that have started within a matter of months. They don't want to do robotics, interestingly, but they know that the future of the department and therefore their livelihoods are safe because we have comprehensive services. And so these new consultants are here, and there are others who've been our trainees that want to come and join us. And that's important for the next decade and beyond. So thank you to all the fundraisers, to the mentors, to the staff who've put in hours of work, and the intuitive team who supervised the implementation for us. Okay, that's the team. Miss Ahmed at the top, Mr. Naidu, going round, Mr. Gallagher, Mr. McCart, that's an old photo, me, Mr. Kadira and Vincent Koo. We really need twice as many consultants to deal with the workload at the moment. We've always needed that number of consultants, but we couldn't appoint anybody. Now we can. We need to get moving and we need to catch up. I was going to show another video, but I think it's quite late now. I'll stop now, but I'm happy to take any questions.
Thank you, Alison Natural. Thank you. Give us a quick